everybody. My name is Guillermo Loyola. I'm a first-year internal medicine resident at UF Jacksonville. And then today I'm going to be talking about mid-ventricular Takotsubo Cardiomyopathy. And it was a very interesting case. And it was triggered by a hypertensive crisis during a dental procedure. And there was a very quick recovery with this case, we'll talk about it shortly. All right. So introduction and background. So Takotsubo cardiomyopathy is a transient form of non-ischemic cardiomyopathy, often triggered by emotional or physical stress, leading to left ventricular dysfunction, right? So the most important part about that sentence is not, as you see. What she did have was like these non-specific ST segment changes. You can't really see it, but like in 2, 3, there was a little bit of like an ST depression, but yeah, very non-specific. It wasn't really following any pattern as like an inferior MI or like, septal or nothing like that. However, with her troponins, it did climb up significantly. So that's why we took this very seriously. It went up to 430 in like around 8 hours. Then slowly it was coming down, and dealing with this patient was very tricky because she would want us to get troponin every like 3 hours. And like at one point we're like, listen, your troponins are downtrending, you're okay, like everything's gonna be okay. And there was a lot of dealing with her, like how much anxious she was. So ideally, in an ideal situation, what you would do is this patient would come in, you would treat this almost like as like an NSTEMI. You would start heparin for 48 hours, and you would cath this patient. This patient, then when you do the cath, it will show non-obstructive. You see this, this like either apical ballooning, this mid-ventricular contraction that's not contracting, or reverse, and then you can make the diagnosis. However, she was so anxious because the past time that she got the cath, they placed a stent that she did not want a stent, right? I mean, she did not want a PCI or a cath. So what we ended up doing is we got a coronary CTA, which confirmed that the mid-LAD stent was without evidence of significant stenosis or occlusion. The TTE that we did, it did show that her EF was 40 to 45%. Her practice.
Now, if anyone has any questions.
Yeah, so usually with an EF of 40 to 45%, you will start starting GDMT. So basic GDMT medications are going to be like your ARBs. If they have CH or heart failure symptoms, you'll do your aldactone, your beta blockers. In this case, we didn't really feel the need to because it was such a transient that you wouldn't treat this as like a CHF or like a heart failure picture. We did just send her home with the Coreg, which is your beta blocker, and then amlodipine, which is a calcium channel blocker, even though the calcium channel blocker is not part of GDMT. But we did not feel the need to restart like full GDMT therapy because of the transient and kind of like the resolution of everything after 48 hours. Yeah, so it's for her. So if it's a normal Takotsubo, usually like people go home with beta blockers. In her case, I think dealing with the stress just because at baseline, she's so anxious. And it's like one thing with Takotsubo is that once you have one Takotsubo, you're predisposed to have more Takotsubo in the future. And with her, well, it's a lot of counseling, but like to answer your question, usually patients like this would be on beta blockers like outpatients, but she just needs a lot of like emotional counseling and kind of knowing that if she gets stressed, she might be predisposed to this again in the future.
Okay, and that's all the time we have. Thank you so much.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.